Drugs to treat pain, opioid analgesics. At the end of this, students should be able to differentiate between endogenous and exogenous opioids, discuss the various routes of administration of opiate medications, summarize the classes of opioids, recognize the signs of opioid misuse, abuse, and overdose, and administer emergency Narcan nasal spray in case of known or suspected opioid overdose. The term opiate refers to compound structures related to products generally found in opium. This is a word derived from opios, a Greek word for juice. Natural opiates are derived from the resin or milk or juice of the opium poppy. Opioids include analgesic drugs such as codeine and morphine, as well as many semi-synthetic and synthetic derivatives. Endogenous opioids are naturally occurring peptide ligands for opioid receptors found in the human brain. The term endorphin is not only used synonymously with the term endogenous opioid peptides, but also refers to specific endogenous opioids, or beta endorphins. The term narcotic was derived from the Greek word for numbing or stupor. Although the term narcotic originally referred to any drug that induced narcosis or sleep, the word has become associated with opioids and is often used in a legal context to refer to substances with potential for abuse and addiction. The use of opioid medication classes of analgesics may be an effective treatment option in the management of chronic or non-cancerous pain. However, this practice continues to be increasingly controversial. Data indicates that more than 700,000 people died in the United States from drug overdoses between 1999 and 2017, with 70,237 deaths in 2017 alone. The age-adjusted drug overdose death rate significantly increased from 6 to 21.7 deaths per 100,000 people. Prescription or illicit opiates were involved in 67.8% of these deaths. Among opioid-involved deaths, the category of synthetic opioids, other than methadone, a category that includes illicitly manufactured fentanyl, was the most common. The prescription opioid category, which includes natural and semi-synthetic opioids, also known as oxycodone and hydrocodone, as well as methadone, was the second most common. The treatment of chronic pain, non-opioid pharmacological therapy are preferred. Prescribers should consider opioid therapy only if the expected benefits for both pain and function are anticipated to outweigh the risks to the patient. If opioids are used, they should be combined with non-pharmacological therapy and non-opioid pharmacological therapy as appropriate. The appropriate use of opioid analgesics. In response to the opioid epidemic, the Center for Disease Control and Prevention has released guidelines for prescribers on the appropriate use of opioids for chronic pain. The CDC guidelines provide prescribers with recommendations for safer care for all patients. These guidelines focus on more specific recommendations compared to previous guidelines on monitoring and discontinuing opioids when risks and harms outweigh the benefits. Recommendations for prescribers are as follows. Opioids should not be the first line or routine therapy for chronic pain. Clinicians should establish and measure goals for pain and function. Clinicians should discuss the benefits and the risks of opioid treatment and the availability of non-opioid therapies with patients. Prescribe immediate release opioids only when treating acute pain. Start low and go slow. Prescribe only the lowest effective dose and carefully determine the need for increased dosage. Do not prescribe extended release or long-acting opioids for acute pain. And follow up with patients and reevaluate the risk for harm. Reduce the dose or taper and discontinue if needed. The therapeutic effects. Opioid analgesics produce effects primarily on the central nervous system. The important among these are analgesia, euphoria, sedation, and respiratory depression. When therapeutic doses of opioids are administered for pain, patients report that the pain becomes less intense or or disappears entirely. In addition to relieving distress, opioid analgesics may cause some patients to experience euphoria. Analgesia often occurs without the loss of consciousness, although drowsiness is commonly occurring, and usually it does not cause slurred speech, emotional lability, or significant impairment of motor coordination. When an analgesic dose of opioid medication is administered to pain-free patients, the recipient may report the drug experience to be unpleasant. Side and adverse effects are described later in this chapter. The healthy patient dosed with opioid may also experience drowsiness, difficulty in mentation, and reduced physical activity. As the dose is increased, the subjective, analgesic, and toxic effects, including respiratory depression, become more pronounced, and the risk of fatal overdose increases. Opioid drugs act by Opioid drugs act by binding to opioid receptors, primarily located in the central nervous system, the peripheral nervous system, and the gastrointestinal tract. The binding of opioids with these receptors mediates both the psychoactive and the somatic effects of these drugs. Opioids, such as morphine and heroin, are considered mu-opioid receptors. It is the activation of the mu-opioid receptor that produces the analgesic, euphoric, and sedative effects involved in the additive qualities of the opioid drugs. Since mu-opioid receptor activation is the most common mechanism of action for opioids, it serves as the focus of this discussion. The route of administration of opioid medications depends on the individual patient's needs. Although the oral route is preferred, intravenous, intranasal, subcutaneous, intraspinal, and intramuscular options may also be indicated. The onset of analgesic effect for oral medication is typically 45 minutes, and the peak effect usually occurs in 1 to 2 hours after administration. This delay must be considered when immediate relief is needed in the management of acute pain, such as post-surgical or breakthrough pain. When the patient is unable to take oral medications, alternative routes of therapy, such as IV administration, may be preferred. The dosing guidelines. Individual patient factors, such as renal or liver dysfunction, may lead prescribers to initiate therapy with an opioid to optimize pain relief while minimizing adverse effects. Weaker opioids can be supplemented by stronger opioids in cases of moderate and severe pain. Antidepressants may be used as adjuncts in the treatment of chronic neuropathic pain and have limited intrinsic analgesic actions in acute pain. However, antidepressants may enhance morphine-induced analgesia. In the presence of severe pain, opioids should be considered sooner rather than later. The opioid dosing schedule typically begins with the administration of a starting dose, then titrates the dose up or down, depending on the patient's degree of pain and demonstrated side effects. As-needed dosing schedules may produce wide swings in analgesic plasma concentrations, resulting in alternating states of uncontrolled pain and sedation. This, in turn, may initiate a vicious cycle where increasing amounts of pain medications are needed for relief. As the painful state subsides and the need for medication decreases, as-needed schedules may be appropriate, which may be also useful for patients with pain that come and go as intermittent or as sporadic in nature. Patients with high pain tolerance may be able to transition from opioid treatments following orthopedic surgery to an anti-inflammatory medication and over-the-counter pain relievers. The absorption. Most opioid analgesics are well absorbed when administered by subcutaneous, intramuscular, and oral routes. However, the first-pass effect reduces the bioavailability of the opioid. An oral dose may be needed to be much higher than the parenteral dose to elicit a therapeutic effect. Certain analgesics are effective orally because they have reduced first-pass metabolism. By avoiding the first-pass metabolism, nasal insufflation of certain opioids can rapidly result in the therapeutic blood levels. Distribution. The uptake of opioids by various organs and the tissues is a function of both physiological and chemical factors. For distribution of opioids through the bloodstream, the molecules bind to plasma proteins and the drugs rapidly leave the blood compartment. Once the drug has left the circulatory system, the molecules concentrate most densely in highly perfused tissues, such as the brain, lungs, liver, kidney, and spleen. Even though blood flow to fatty tissue is lower than to highly perfused tissues, accumulation in adipose tissue can be very important, particularly after frequent high-dose drug administration or continuous infusion of opioids that are slowly metabolized. Metabolism. Most opioids undergo extensive first-pass metabolism in the liver before entering the systemic circulation. Opioid metabolism in the liver requires that the cytochrome P450 enzyme facilitate metabolic reactions. Opioids are typically lipophilic, which allows them to cross cell membranes to reach target tissues. Excretion. Polar metabolites of opioid analgesics are excreted mainly in the urine. Small amounts of unchanged drug may also be found in the urine, although small molecules are found in the bile. Intracephalic circulation represents only a small portion of the excretory process and those of the polar metabolites. Patients with potential renal insufficiency should be carefully evaluated before receiving high-potency opioids, especially when administered at high doses due to the risk of sedation and respiratory depression. Individual patient factors may lead prescribers to initiate therapy with an opioid to optimize pain relief while minimizing adverse effects. The World Health Organization 3-step pain relief ladder encourages using more conservative therapies before initiating opioid therapies. Weaker opioids can be supplanted by stronger opioids in cases of moderate and severe pain. However, antidepressants may enhance the analgesic effects. The opioid dosing schedule typically begins with the administration of a starting dose and then titrates the dose up or down, depending on the patient's degree of pain and demonstrated side effects. As-needed dosing schedules may produce wide swings in analgesic plasma concentrations, resulting in alternating states of uncontrolled pain and sedation. This in turn may initiate a vicious cycle where increasing amounts of pain medication are needed for relief. As the painful state subsides, the need for medication decreases. As-needed schedules may be appropriate, which may also be useful in patients who present with pain that is intermittent or sporadic in nature. Patients with high pain tolerance may be able to transition from opioid treatment following orthopedic surgery to an anti-inflammatory medication and over-the-counter pain reliever. Opioid addiction or opioid use disorder can affect one's health and relationship to the point that the person's life becomes organized around using the drug. Opioid addiction can present over the span of a few weeks to much earlier, depending on each individual patient, and can worsen over time. The diagnosis for opioid use disorder requires presentation of at least 2 of the 11 criteria over a 1-year period of time. The following are examples of symptoms of opioid use disorder: the inability to control opioid use, uncontrollable cravings, drowsiness, changes in sleep habits, weight loss, frequent flu-like symptoms, decreased libido, lack of hygiene, changes in exercise habits, isolation from friends and family, stealing from family, friends, and businesses, and new financial difficulties. Combinational therapies. In general, the use of combinations of drugs that have the same mechanism of action is not warranted. The same principle holds if the drug has overlapping targets and opposing effects. On the other hand, certain opioid combinations are useful. For example, in chronic pain states with periodic incidences of breakthrough pain, the patient may receive a slow-release formulation of morphine for baseline pain relief, and the acute incident or breakthrough pain may be managed with a rapid onset and short-lasting formulation. This is a table explaining the combination of analgesics, opioids, and NSAIDs commonly prescribed in the sports medicine facilities. Opioids are often used on the second step on the World Health Organization pain ladder in the management of acute pain and some types of chronic pain. Although they are controversial and potentially addictive and abused, drugs in this medication class may be effective treatment options in the management of chronic non-cancerous pain. Opioid choice should be based on a patient's acceptance, analgesic effectiveness, and pharmacokinetic, pharmacodynamic, and side effect profiles. The use of opioids often leads to opioid-induced constipation. Patients taking opioids should be counseled on proper intake of fluids and fibers and add a stimulant laxative or stool softener to the dosing schedule. Opioid-induced constipation is a reduction of the spontaneous bowel movements from the baseline to typically less than 3 bowel movements per week after commencing opioid therapy. In some cases, opioid-induced constipation may not respond well to laxatives. Therefore, prescribed medications have been tailored for this condition. Peripherally acting mu-opioid receptor agonists are intended to reverse the constipation associated with opioids. Examples of these medications are Relistor and Montavic. These medications should be administered precisely according to dosage instructions and ceased when the opioid use ends. They are contraindicated for patients with a GI tract obstruction or hepatic impairment. Opiates share related pharmacological attributes and exert a profound effect on the central nervous system and gastrointestinal tract. Mood changes, sedation, nausea, vomiting, decreased GI motility, constipation, respiratory depression, dependence, pruritus, and tolerance are all evident in varying degrees with all opioid agents. Tolerance to the side effects, except to constipation, often develops over time. Caution is also urged when combining opioid analgesics with alcohol or other central nervous system depressants, such as benzodiazepines or other sleep hypnotics, because this combination can result in potentially lethal respiratory depression. Opioid warnings. Narcotic opioid analgesics are one of the most widely used analgesics for pain relief. However, they have been overused, overprescribed, and misused, resulting in over 2 million people in the United States having a substance misuse disorder connected with prescribing narcotic analgesics. The Food and Drug Administration guidelines for use recommend that opioids should be reserved for patients for whom alternative treatment options are ineffective, not tolerated, or would otherwise be inadequate to provide sufficient management of pain. The 3 primary FDA opioid warnings are as follows: risks of addiction, abuse, and misuse, life-threatening respiratory depression, and the risk from concomitant use from benzodiazepines or other central nervous system depressants. Narcotic analgesics are potentially addictive, and the risk of becoming emotionally and physically dependent on these drugs increases as the patient takes higher doses for longer durations of time. When prescribed by a physician and used for short periods of time, for example, less than 5 days for pain relief after surgery, the risk of becoming addicted to narcotic analgesics is relatively low. But abuse can happen at any time. The most common opioids that an athletic trainer is likely to encounter while providing medical care to healthy, physically active people are listed in a table. 8.3 on this slide, the classes of opioids. Codeine is a low-potency opioid used to treat mild to moderate pain, as well as for its antitussive and antidiarrheal effects. Since its abuse potential is highest when used as a single entity, it is often combined with other analgesic products, such as acetaminophen. Because codeine has a considerably higher oral bioavailability than morphine, it is also used in conditions for which a low-potency oral opioid analgesic is preferred, such as combined with acetaminophen or aspirin. Fentanyl is a synthetic opioid agonist used for severe pain, and it is 100 times more potent than morphine. Fentanyl is most widely used for intraoperative and periprocedural analgesia due to its high potency and rapid onset of action. The time to peak analgesia effect after IV administration of fentanyl is less than 5 minutes. It is much less than for morphine, approximately 15 minutes, and the recovery from analgesic effects also occurs more quickly. However, with larger doses or prolonged infusion, the effects of fentanyl become more lasting, with durations of action becoming more similar to those of long-acting opioids. Fentanyl is used in the management of acute to severe pain, but is also used in chronic pain treatment and is becoming more widespread. Because fentanyl is poorly absorbed in the GI tract, the transdermal or buccal administration methods are preferred when using the drug for chronic pain management. Transdermal fentanyl patches provide sustained release for 48 to 72 hours. Illicit use, self-administration of chewing of fentanyl patches or lollipops can be deadly, and athletic trainers must be aware of this potential if these modes are prescribed to patients. Opioid antagonists such as naloxone. The opioid antagonist naloxone, also known as Narcan, binds competitively to opioid receptors but does not produce an analgesic or opioid side effect response. Therefore, it is used most often to reverse the toxic effects of opioid agonists. Naloxone, also known as Narcan, is indicated for the emergency treatment of opioid overdose as manifested by respiratory or central nervous system depression. Opioid antagonists, particularly naloxone, have been established in the use of treatment of opioid-induced toxicity. Naloxone is administered intranasally or intramuscularly and is intended to immediately administered as an emergency rescue drug. Naloxone can be administered every 2 or 3 minutes while waiting for emergency medical assistance. Immediate transport to the hospital is necessary after administration of naloxone. This is an illustration of the reversing of an opioid overdose, the opioid receptor antagonist mechanism of action. This illustrates the opioid receptor's antagonist mechanism of action. In summary, opioids are effective treatments for acute and chronic pain. There are concerns regarding overdose deaths, secondary to increasing the prescription for chronic pain. Athletic trainers should understand the warning signs of abuse and misuse, especially with opioids. Athletic trainers should be proficient in the use of naloxone and Narcan, and the activation of emergency medical services.